filtering in as well, and they'll join us. So today we have Dr. Sankari from the Division of Pulmonary Critical Care Medicine talking to us about sepsis. So as a brief intro, although many of you have probably worked with her and know her, Dr. Sankari works here in our department of medicine within pulmonary critical care. She completed her fellowship training here at CMC in 2021. She also serves as APD for the Pulmonary Critical Care Fellowship. So for those of you interested in applying, she's a good person to get to know. She's a member of the Sepsis Committee at UHCMC, where she is the inpatient lead resource. Her interests include critical care medicine, quality improvement, and patient. Thank you
for the introduction and thanks for attending. Our webinar today is about sepsis. All of you guys have taken care of many septic patients. No matter if you're just a resident or have been attending in practice. And hopefully this will serve as a good reminder of the strategies we focus on helping our patients survive this condition. I do not have any disclosures. As most of you know, September is Sepsis Awareness Month. However, I like to think that every month is Sepsis Awareness Month. And for the purpose of this talk, we're going to reinforce sepsis as a clinical emergency, review the current evidence for management strategies, focusing particularly on antibiotics and resuscitation, then highlight some challenges and opportunities for improving inpatient recognition and management of sepsis. Again, I don't have, there's tons we could talk about. We only have an hour. So again, this will be kind of brief highlights of all the work that has been done. So I want to bring us all back a little bit. So when I was studying for step one, I got really into scrubs for some reason. So when I was looking for a picture of an intern, I found this picture, although I don't remember this character per se. I think this was like based on like the offshoot of scrubs, like scrubs interns didn't do particularly too well. But I want us all to take a step back and imagine ourselves as an intern. This may be immediately present to you or in some time, and put yourself in his shoes. So you're a new intern covering wards on a night shift, your first one. So you're excited, ready to take on the world. You just finished getting sign out from about 30 plus or maybe 40 plus patients. And then you get this message on haiku, patient on Lakeside, and this has two sets of vital signs, a blood pressure of 100/60 and a heart rate of 120. So you have a couple options, maybe some things that are floating in your mind. Maybe you start to panic because you got 4 other haikus at the same time and you're not really sure which one to address first. You may say, okay, I'm going to order a bolus and kind of triage the rest of my patient messages. See, you're like, I'm really out of my wheelhouse here. I'm going to call my senior, call the doctor and after go see the patient, or maybe you're briefly entertaining a different career path. Maybe this wasn't exactly what you expected. So again, just want to highlight how ambiguous sometimes these presentations are and some strategies that we have in place in the hospital to help support you guys taking care of these patients. I really want to highlight again sepsis as an emergency. Just as when you go see a patient and you're concerned for a stroke, you call code BAT. Go see a patient having chest pain, you get an EKG that shows ST elevation. We're calling a code STEMI. I want you to think about sepsis also similar to that point, because we know that there's very time-sensitive interventions that need to be done. This is an infographic that's been created from the Sepsis Alliance, which is an organization devoted to increasing awareness and strategies to help sepsis here. And outreach. And they came up with this acronym TIME, which I think is really fitting. Again, maybe a little bit more geared to the lay population, but it kind of cinches home the point. So we all know that the impact of sepsis is very wide. When we're specifically looking at the United States, we see that there's 1.7 million cases annually. We also know that 1 in 3 patients who are hospitalized end up with sepsis, and it accounts for 270,000 annual deaths. We also know there's an increased cost to it. So again, a lot of things that can be addressed. We ask ourselves, what is the definition of sepsis? The most current definition is the SEPS3 definition, which is basically an interplay of the host response to infection. This dysregulated host response in turn causes organ dysfunction, which we can objectively categorize by using our SOFA score. And then for folks that have septic shock, this detrimental host response turns into profound circulatory dysfunction. This portends an increased mortality risk. So going back to the host response and sepsis, this is just a little cartoon that highlights some of the pro-inflammatory and anti-inflammatory responses that a patient can have. Again, the purposes of this talk is not really to dive too deep into this, but just know that for folks that have an anti-inflammatory response, this actually portends higher risk for these patients and predispose them to nosocomial infection, viral reactivation, and endotoxin tolerance, and can relate to deterioration. Before we get into the initial management of sepsis, want to remind ourselves kind of the history behind the different definitions in the surviving sepsis guidelines. So as early as 1991, the first definition of systemic inflammatory response came out. We now know that that's not entirely specific to sepsis, but maybe can clue us in on something is happening to our patient. And then our first landmark trial for early goal-directed therapy, which was published in 2001, and then all the way to most recently our 2021 surviving sepsis guidelines. And as you can see, there are changes in how we define sepsis throughout this time frame. So this should be just a review. So we all know, hey, I know how to treat sepsis. There's infection, regulated host response, organ dysfunction, got a diagnosis. I know I need to get a lactate blood cultures. I know I need to start antibiotics, and I know I need to give some type of resuscitation to the patient. This is a QR code that leads to the most current surviving sepsis guidelines that were published in 2021. So again, going back to our diagnosis, seems simple enough on paper, but we all know in clinical practice it's very challenging to diagnose. Oftentimes we're showing up at a patient's bedside and we only have part of the, part of the whole picture, and we're trying to put things together while actively trying to treat the patient. We know that a lot of the signs and symptoms of sepsis have an overlap with other disease processes, and we don't really have a holy grail or, a gold standard of sepsis diagnosis. Although blood cultures have been cited as a gold standard, we know that blood cultures can be negative in up to 40% of cases, and they're not immediately available to us at the time of seeing the patient. But we'll talk a little bit about some, strategies and different, kind of research looking into how we can optimize diagnosis later on in this stuff. I want to focus next on antibiotics. So we know antibiotics, we have an infection, so definitely treating with antimicrobials is going to be one of the first things that we do. This table is taken from the surviving sepsis guidelines, and it kind of helps you triage, well, how soon should I give antibiotics to what type of patient? So depending on how high your suspicion for sepsis is, will push you towards giving antibiotics sooner, within an hour. If you show up and your patient is acutely ill, like they're in shock, you may not necessarily have enough time to get your clinical data to support your diagnosis. So you're most likely going to start antibiotics so that we don't, have an increase in morbidity and mortality. So where do these recommendations come from? We know in the literature there's been mixed studies about antibiotic timing. So one of the studies that has been cited was a study done in 2017. A study looking at 80 patients that included 35,000 patients. And what they found was that, was each hour from time of, recognition of sepsis or ED triage, there was an associated increase in mortality. And this was specifically true of those patients that were diagnosed with septic shock. Kind of similarly, New York State mandated the sepsis bundles. This came out of what we call Rory's rules. A young kid who came in through the ER was a scrape on his arm, had early signs of sepsis, was discharged home, came back in Florida septic shock, ultimately died. So one of their initiatives was focusing on these bundles, which includes identification, antibiotic, and fluid resuscitation. So 49,000 patients were included in this. The overall mortality is 22%, which is on par to what we're currently seeing now. Noted that delays in bundle completion in antibiotic completion increased our risk-adjusted mortality. But also noted that there wasn't really a strong association between timing of fluid completion and mortality benefit. Okay, I will turn forward. Okay. So we know antibiotic timing is important, but is there any particular patient or patient population that's going to benefit the most from starting antibiotics early? We know that there's varying presentation of sepsis across different populations. So this was a study that was recently published within the last year or so. Was an observational study trying to determine if there's a heterogeneity of benefit from early timing antibiotic for sepsis. So it actually included 173 hospitals and included 273,000 patients. And this included not only like teaching hospitals, but also VA hospitals as well. And they used 3 different kind of statistical strategies to try to determine what populations may have an earlier benefit to antibiotics. Their shorter time to antibiotics was defined as antibiotics less than 3 hours from time 0. And their time 0 definition was actually the CDC adult sepsis event definition. And then also the longer time to antibiotics was between 3 and 12 hours. So the 3 methods that they used was a conditional average treatment effect, was a multivariable Poisson regression, a causal forest mapped ID characteristic associated with the greatest benefit from shorter time to antibiotics, and a logistic regression was time to antibiotics modeled as time, assuming that there's a nonlinear relationship between mortality and time to antibiotics. This is a snapshot of the overall characteristics of the cohort, and I'm going to highlight several things they found. This was the Poisson regression. So you can see, not surprisingly, there's several subgroups in here that are going to have benefit, have a higher absolute mortality reduction. Folks that had a lactate elevation, organ dysfunction, multiple organ dysfunctions. Sorry. 3 here, and metastatic cancer and shock. This was the multivariable logistic regression, and sorry, this is a little hard to see, and I'm actually sorry, I have to turn my head to see the pointer there, but so looking at this is shock and the metastatic cancer group. So the folks that had shock, higher mortality when there was a longer time to antibiotics, as well as the metastatic cancer group. And then this is our causal forest map, lots of colors, green and red. So basically, just to point out that the top 2 here that had the highest benefit from earlier time to antibiotics were the comorbid metastatic cancer and the shock group. So again, there are limitations to the study. Retrospective group, using kind of a different definition for time 0 for sepsis, but may help us identify when we're working on our sepsis programs, what disease populations would have an added benefit from stronger efforts to try to improve our antibiotic delivery times. Again, there's a lot of diagnostic uncertainty with sepsis. So this was a nice kind of editorial that was published, I believe, in ATS that kind of highlights, okay, well, kind of balancing the risk for mortality and morbidity was our risk for developing MDR, infections and added harm from empiric antibiotics, looking at how sick the patient is at hand, looking at how likely the patient has infection while we're trying to get objective data. So next, I'm going to talk a little bit about resuscitation. And we all know that the goal of resuscitation is to optimize delivery of oxygen to our tissues. This has to do with our cardiac output and our arterial concentration of oxygen. So as you can see here, looking at stroke volume and heart rate as components of our cardiac output. And then reminding ourselves that our mean arterial pressure is a product of our SVR and carbon monoxide cardiac output. So again, just put this in your mind when you're trying to say, hey, I need to resuscitate this patient. Really, your goal is to try to maintain a cardiac output. And this can, in different patients, may look like different things. So first I want to answer, do we know how much fluid should I give my septic patient? So the recommendation from the current guidelines was a change from the 2016 guidelines, actually downgraded the strengths of recommendation for this 30 cc's per kg of IV crystalloid infusion for septic shock. And why is that? So let's take a look back to some of our previous studies. So the first study that really looked at this usually goal-directed therapy was a Manny Rivers trial. Everybody was following a standard protocolized way of managing these patients through an emergency room. And they noted an improved hospital survival. Well, that was great. Fast forward 13 years later, there was changes in kind of standard of care of how we handled our septic patients. And we had 3 challengers to the early goal-directed therapy trials, which were the Process, Arise, and Promise trial. And then those 3 were analyzed in a meta-analysis in PRISM. And this is what I'm showing you here, this Kaplan-Meier curve that shows there was no difference between this early goal-directed therapy versus usual care group. So to say, well, maybe our standard of care got better, or more cautious of overloading patients with fluid, we know that additional fluid actually can harm certain patients. More recently, I think a few of the residents may have discussed this in Journal Club, or we talked about it in the unit. The classic trial that was published in New England Journal of Medicine in 2022 that looked at ICU patients that came from the ED with septic shock, looking at whether a restrictive approach to fluid was better than the standard of care. This was a randomized controlled trial. The definition that they used to include patients was a SEPS3 definition, about equal number of patients in each group, and they looked at deaths by day 90. They didn't see a difference in the death by day 90 either between the restrictive and standard of care group. They had a few secondary outcomes that looked at number of days alive without life support and days alive and out of the hospital. Didn't really see a signal there. Conclusion was that, you know, the restrictive strategy didn't result in fewer deaths than it might be compared to standard IV fluid, but let's take a closer look. So this was a table highlighting the cumulative fluid balance. And if you bring your attention towards the end of this after 90 days, you can see, you know, the median fluid between the restrictive and the standard fluid group was maybe about 800 cc's, and the difference in the median was about 700 cc's. So they weren't too far off from each other at day 90 in terms of total volume status. Additionally, there was noted a lot of protocol violations in this study. A lot of folks in the restrictive group were given fluid bolus without following the protocol. And then in the standard group, majority of the violations were people weren't giving fluids when fluids were recommended. So this has kind of in line with how we generally practice ICU care. We're generally hesitant to give additional fluid unless the patient absolutely necessarily needs it. And then of note, all of these patients got at least 3 liters of fluid prior to enrolling in the study. The next fluid study we'll talk about is the Clovers trial that was published in 2023. So it also tried to answer a similar question for folks that have hypotension related to sepsis. Is restrictive strategy with a protocol for initiating vasopressors better? You know, does that show a lower mortality before discharge by day 90 versus a liberal fluid strategy? This was a multi-centered, randomized, unblinded study. They didn't have as strict, you know, definitions of their sepsis diagnosis. They just said suspected confirmed infection, sepsis-induced hypotension, and then everybody at least got 1 liter of fluid, and then they were randomized either restrictive or local. So the amount of patients in each arm were similar to the very strict protocol, which I'm going to show on the next slide. And then they looked at, you know, mortality before discharge home by day 90. Didn't really see a difference, a statistically significant difference. And then in the secondary outcomes, they didn't really see that much difference between the groups. I will note that part of their protocol also included that vasopressors could be administered peripherally. And I think for at least, I want to say maybe up to 60% of patients had those administered peripherally. Again, this is the protocol that you can see here. This is the restrictive on the left. This is the liberal fluid group on the right. And then kind of going into kind of more fluid balance and duration of pressor use. You know, there were a little bit more of a difference between the restrictive and liberal fluid strategy compared to what we saw in the classic trial. So one of the strengths of this study was that there was a high protocol adherence. Some weaknesses with the study included that, you know, the fluid administration was not weight-based. So if you're thinking about, you know, your tiny, you know, 50 kg little old lady versus a bigger patient, that difference in fluid is significant. And then in order to give more fluid, there were some parameters for looking at lactate and blood pressure and echo, but there wasn't necessarily a guide of, okay, let's use a passive straight leg raise in order to determine whether the patient needs more fluid. So takeaway, you know, I think we need to rethink our resuscitation target. It's not a one size fits all. We've all, you know, rotated through the ICU and you see how differently our patients handle excess fluid. So some of the studies that are upcoming are one, the ARISE fluid study, which is kind of a continuation of the ARISE study that was done in Australia. And then the Andromeda Shock 2 study, which is looking to try to put patients into hemodynamic phenotypes based on diastolic arterial pressure, barring arterial line, and kind of protocolizing them to fluid and vasopressor strategy. The next thing we'll chat about is, well, is there a difference in what fluid I pick to give to my patients? So this was a changed recommendation from 2016 to 2021. So beforehand, there wasn't really much of a recommendation between crystalloid or balanced fluid. 2021, although it's a weak recommendation, tends to favor more giving balanced crystalloids. So where is the, you know, data behind this? So several studies in the last, you know, 5-6 years that look to see the difference between giving balanced crystalloid versus saline. Some of them included all critically ill patients. Some of them included just septic patients. Long story short, you know, majority of these studies favored balanced crystalloids for basics trials in 2021, where they looked at a subgroup analysis of folks that had traumatic brain injury, and that patients had actually a higher mortality in the balanced crystalloid group versus the normal saline group, which could be extrapolated to maybe changes in osmotic gradients and intracranial pressure. Again, when we're giving maybe 1 to 3 liters of fluid at a time, the selection of fluid may not matter too much, except in the patients that have traumatic brain injury. It's just fluid, right? We all can remember this picture of this, you know, Michelin Man, puffy guy, Ghostbusters, you know, thing. We know that a lot of organs are detrimentally affected by vascular congestion. We also do have data to suggest that, you know, increased fluid balance does cause increased mortality and morbidity for patients and increased hospital stays. So this concept of resuscitation comes out. It was coined in 2014, and I like this, you know, picture because it kind of highlights what we usually are doing at the bedside, but it kind of outlines it for us. So, you know, in the immediate kind of shock phase, when patients are deteriorating, we're giving fluids, we're resuscitating them. Once they've stabilized, we're trying to avoid any extra fluid to prevent vascular congestion. And then at some point, we're making the decision, okay, well, we need to actively try to get the fluid off of the patient, whether it's through diuretics or ultrafiltration. Is there an optimal strategy for deresuscitation? Work in progress. I know there's a lot of different protocols and studies out there looking at what would be the best strategy, keeping in mind your, you know, patient's underlying clinical condition. A lot of us love ultrasound. So this is kind of like the newer kid on the block, which is Sepsis ultrasound. So our venous excess ultrasound score. So it actually is 4 different measurements of pulse wave Doppler of venous waveforms, looking at IVC, hepatic veins, portal veins, and renal veins. So it can assess kind of vascular congestion in different organs. And, based on the grading can tell us, how bad our venous congestion is and could perhaps maybe guide us into, volume removal for these patients. Again, it's one of those things that, you can see it takes some time to do, making sure you're in the right plane, getting accurate measurements. But if you learn how to do it reasonably well, it could be used to help guide your fluid management in patients. So how do we put it all together at the bedside? So again, I like to think of taking care of septic patients as basically showing up, partially completed puzzle, and there's a bunch of missing puzzle pieces, and you're being timed to try to put it together in time. I do want to focus a little bit about hospital sepsis because you guys take care of the patients who are admitted in the hospital. We know that they're more likely to die in the hospital compared to their ED cohorts, spend longer time in the ICU, have more comorbid conditions. They're less likely to be discharged home, and there's also an associated increased average hospital cost. So what can we do to try to optimize care for these patients? So bringing us back to our initial management, kind of you guys are our frontline responders to these patients. What can we do in terms of diagnosis, screening and lab testing? And then what can we do about our care delivery? So protocolizing care delivery teams, following standard protocols across the hospital, making sure our interventions are accessible to us. And we know that antibiotics need to be put in to our patient in 60 minutes. They need to be readily available to us at the time we recognize the patient exactly. So sepsis screening tools, it seems like a lot of alphabet soup, right? So you have, SOFA scores, SIRS, NEWS, MUSE. You have, a lot of proprietary predictive models alerts, which, our Epic sepsis model fits under that. A lot of institutions work with their IT departments and machine learning to develop their own alerts. QSOFA, as as a solitary tool to really diagnose sepsis or screen for sepsis, fallen out of favor, although it can be useful to detect a critically ill patient because it's quicker to calculate. Keep in mind these MUSE and MUSE score, which I've highlighted here, a lot of them are based on vital signs. So that's really limited by the frequency of which you're obtaining vital signs on the floor. And think about, doesn't account for the change, necessarily the delta. For instance, if you had a patient who systolic is now 100, would you be more worried if their systolic 24 hours ago was 110 or it was 150? So again, it doesn't necessarily discriminate between these two patients, which you would be more worried for the patient who dropped 40 points by their systolic blood pressure. Now, Epic has their own predictive, sepsis model, and I believe currently our institution is looking at our internal data for that before piloting this on the floors. So this article came out in, I believe, 2021, and it caused a lot of notoriety and upset a few people because it basically demonstrated that, hey, we were missing a lot of patients with sepsis with this predictive model, and we needed to evaluate a lot of patients more frequently to try to pick up one septic patient. One of the things I want to highlight was that was a retrospective study. And at baseline, it identified maybe like 7% of patients who, were septic who weren't already on antibiotics. So that number was relatively low to begin with. But it just goes to show that when we're implementing some of these predictive models, looking at what's going on in your own institution and how, kind of almost like a pre-intervention assessment may be more useful than kind of blindly assigning a random, cutoff score. One of, the more recent studies, is more of like a quality improvement study that was published in 2023, which is a single center study, tried to implement this ESM in their facility. I believe it was a tertiary care hospital in Greenville, South Carolina. And they actually looked at like 4 months of data. They had 11,000 alerts, which is insane. But they were able to pick a cutoff score of 5 in order to, be sensitive enough to pick up septic patients. Their definition of sepsis was actually validated against the sepsis code, not necessarily sepsis 3 definition or the CDC definition of adult sepsis event. So that was one of the things to note was this study. And they did see a mortality improvement, their baseline period and intervention period. Their intervention period lasted about a year. And they had different educational efforts throughout the hospital system to educate nursing staff as well as physicians. You can see at baseline, their time to antibiotics, was pretty high, 150 minutes. They got it down to 90 minutes, which is a significant improvement, but still elevated. And their mortality, was able to be reduced. Now, again, whether or not that was really related to their intervention or not, or perhaps increased awareness about the condition through their educational campaign, can't really say. Other systems have looked at, developing kind of, sepsis dashboard and different, augmented intelligence systems to help clinicians identify patients and get them timely care, do CAS1. And then this study was published in Nature that looked at a TRUES machine learning based early warning system that was looked at in several hospitals in the DC area. And what they saw, post implementation of this is that for patients that had an alert that was recognized in a timely fashion, they had a median decrease of time to antibiotics by 1.8 hours, and there was a trend towards decreased mortality. So again, some limitations when you're looking at machine learning, early warning scores, what have you, really looking at your patient population and how implementable it is in your institution. I'm not going to spend too much time on this, but everybody is looking for the new biomarker to help us take care of our patients, not only in sepsis but other disease processes. If you put it in a PubMed search, you're going to get a ton of hits out there. What do we actually use? Again, I don't think there's one biomarker in particular that's going to be your kind of gold standard, holy grail, but there's a lot of studies looking at combination of things. I think the most studied one was procalcitonin and CRP, and there's a lot of newer kids on the block and a lot of studies coming out, so stay tuned. I'm not going to spend too much time on this either, but just so you know, you may hear of these things. So understanding what they're designed to do and how they can be used, especially if you go on to practice in different institutions. We have right now 3 FDA cleared diagnostic assays, so meaning helps us with sepsis diagnosis, IntelliSep, Septicide Rapid, and probably the more study is monocyte distribution list. They all have some kind of limitations on the population of patients they can be used in. For instance, in IntelliSep, we can't use that in hematologic malignancies. The sample is only stable for 5 hours. So if you're not running it quickly, you're not going to be able to get a good result. Septicide Rapid, there's also some limitations where if you're not suspecting the patient of sepsis, the score may be intermediate to begin with, so it may not necessarily help you. And then probably the more studied is our monocyte distribution lists. Again, in pediatric populations and hematologic malignancy, their performance have not been established. So just keep in mind, these things are out there. Take a look when you're looking at their studies, seeing what populations they're used in, see if this could be applicable to the patient. Downtime. Okay. One thing I do want to highlight, I think this is very obvious. There's tons of studies on time of day with patient care delivery, and time of day changes with antibiotic administration. So this study was published in ATS, looked at association of time of day with delays in antimicrobial initiation amongst patients with hospital onset sepsis. So actually, they excluded patients that came in through the ED with sepsis. And their median time from admission to diagnosis of sepsis was about 7 days. So this is well into their stay in the hospital. And right here, you can kind of see the distribution of, time of day, like by hour of, when the diagnoses were made. So 7 is here, so 7 a.m., then all the way to 6 a.m. And what they're showing here, they are also using the CDC definition of an adult sepsis event. So it has to do with kind of timing of when blood cultures were taken, organ dysfunction started, and whether or not antibiotics were started. So as you can see, as we go through time, during the earlier hours of the morning, our diagnosis is primarily remain from like organ dysfunction, which you guys, you all notice when you're getting called in the middle of the night, your nurse is calling you, hey, this guy's more encephalopathic. That's going to be the reason why you see the patient, as opposed to maybe earlier in the day where you're doing rounds, you're actually looking at labs, and then you're making the diagnosis based on, some ordering of labs. Not surprisingly, so this, I believe this study was done in 5 different hospitals, there was like a tertiary care hospital, a couple community hospitals. Their change of shift times were at 7 and 7. And not surprisingly, change of shift times were bad with giving antibiotics. Obviously, there's a lot of things happening. So at 7 a.m. and at 1900, there was a drop. So basically, this y-axis showing the probability of whether or not antibiotics would have been started within the hour of making that diagnosis. When they looked at mortality, though, so on the y-axis down here, that shows probability mortality and then hour of day of sepsis onset. There wasn't too much of a signal between, hour of day and whether or not the patient, had a bad event. Now, again, that could be more related to kind of looking at everybody on the same playing field, not looking at different subgroups that may have a stronger association with mortality and time to antibiotics. Again, worthwhile looking into further. And then just a note on sepsis response teams, there's been a lot of studies on sepsis response teams. This is just an example of one that was incorporated into like a hospital-wide initiative. Developing their own alert for detecting sepsis, education, and then standardizing their response. Some improvement in mortality. Again, it's not always a direct linear relationship. So that's why looking at things like time to antibiotic administration may have some more meaningful insight on ways you can improve your process. And then decrease in hospital lengths of stay, decrease in mechanical ventilation, and then compliance. And then another thing to think about, on a higher level, when we're looking at, improving sepsis outcomes, what are we doing, as a hospital, as a system to reduce hospital-associated infections? So, our hospital system has teams working on CODI prevention, CLABSI prevention, VAP prevention, so collaborating, with these efforts to improve outcomes for our patient. So one of the things I really want to highlight, or kind of one of our bigger initiatives, is like for our definite septic patients with shock, getting those antibiotics in a timely manner. One of the things we've noticed trends, transitions of care are definitely high-risk points. When we're looking at patients that are getting admitted from the ED to the inpatient, long boarding times, having that reassessment after giving volume administration. Oftentimes, these patients are getting fluids in the ED, then getting admitted to the inpatient side. And it's, our responsibility to make sure we're going to reassess the patient, make sure that they responded appropriately to fluids and that they don't need escalation of care. And then additionally, when we're transferring a patient, from the floor to the ICU, this is where a lot of times antibiotic delivery can get missed. The patient is in profound shock, need to try to support their blood pressure. We're rushing them up to the unit, and then we're like, oh, by the way, who gave the antibiotics? So there's a couple of things that we're trying to work on to help improve this process, for the inpatient team. So that way we don't miss these high-risk transition points. So what can you guys do for your septic patients? Use the order set. Why do I say that? Does anyone want to tell me? No? Too shy, okay, so the stat orders for the antibiotics, where does the nurse retrieve those from? It's on there. The Omnicell, which are located on each of the floors, so that helps reduce that time to antibiotic. Call rapid response, just like you would call a code BAT for a stroke patient, or, code STEMI for a patient having a ST elevation MI. This will help facilitate, all of the care that needs to be done in a timely manner for that patient. If the patient needs to be transferred to the ICU, they can also help with that transfer. And one of the things I want to always highlight to you guys is communicate. When you're seeing these patients, you're kind of putting it together. This patient's more encephalopathic, they're hypotensive, tachycardic, they have a new infection. I think it's sepsis. Why is it so important to say it out loud? When you say that word, it tells your bedside staff, say, okay, like when I'm thinking sepsis, I know I need to get antibiotics in, I know I need to get fluids in, I know I need to get lab work in. It helps kind of set the stage because there's a certain illness script that they have to follow in order to take care of the patient. Does anyone know I put a map of the hospital up here? Okay, so one of the things that I didn't realize until more recently, so let's say you didn't put your antibiotic order through the sepsis order set. This is at main campus. Where do we get our antibiotics from? Seidman Pharmacy. What if you're over on Lakeside? How long does it take for you to go from Lakeside to Seidman and then Seidman to Lakeside? Provided you're not like a marathon runner, like average. 20 minutes. How long does it take for a pharmacist to prepare an antibiotic that was put in as a routine order? 15 minutes. Okay, so you're already 35 minutes behind. That's provided that everything else goes as planned. So that's why when we're really pushing you guys to put in the orders through the order set, it bypasses that workflow. If you ever have any issues with antibiotic availability, let's say you're ordering Zosyn that's not in the Omnicell, please reach out to the pharmacy immediately and then send, our sepsis coordinator and myself an email, okay? That way we can help troubleshoot. So we're working on making sure on the inpatient side that our Omnicells are, fully stacked. We're working with pharmacy to make sure that there's no missing doses of antibiotics. And then this is the sepsis order set for those of you that may not be familiar with it. It's similar to what we had in All Scripts for those of you that used All Scripts. Again, our labs are the first thing that pop up. The fluids are the next thing that pop up. When you pull in the fluid, so I picked 500 cc's, you see this red exclamation point. So if you're ordering anything less than 30 cc's per kg, it has a reason for why you did that. So you can click it, that'll serve as your documentation. So you don't have to worry about going back in your note, putting it in your note. That's to help, be in compliance with our CMS standards. And then our antibiotics, so over here, I basically put, I selected community acquired pneumonia was a no beta-lactam allergy, and it already has antibiotics pre-selected for you. This list was vetted by the infectious disease team in pharmacy. And then have you guys seen this form before, the sepsis huddle documentation? No, okay, so one of the things we're trying to reinforce too is that communication piece, which this serves also to reinforce. So if you go under your sepsis tab in Epic, it has a little sidebar that says sepsis huddle. It's basically what we just talked about, just saying, hey, I think it's sepsis. You're just documenting it here. And what you can do is then put them on a different pathway. If you click, I'm not sure, maybe it's probable sepsis, you can click yellow. Red is like probable or definite sepsis where there's shock. It puts them on, on the red list, and we start the sepsis timer. So it gives you some time points of when you need to do certain interventions. And then, the system created this dot phrase, which you can put in as your reperfusion note. It's literally just a dot sepsis. And then it just pulls in the information about the patient and then when you did the reperfusion exam. I do want to highlight, one of the initiatives that, the system has been working on that has garnered a lot of success and has been highlighted in the Sepsis Alliance. So the peer-to-peer sepsis champion experience. So, spearheaded by our sepsis coordinators, nursing education. So there's over 100, I think, members so far. Correct me if I'm wrong, Amanda, and there's about 15 or even more now CMC champions. So what that tells you is that, nursing is also being educated about these interventions. So when you're using this terminology and language to communicate with them, we're all on the same page and we know what targets we need to hit. So I just want to kind of go back to our case of our intern. So we're going to make it pretty simple for you guys here. You go see the patient, he's altered, cloudy urine, tell nurse, I think this could be sepsis. We start them on the care path. You're able to get the antibiotics from the Omnicell, get them fluids. You call rapid response to help with IV access. You go back and reassess your patient and life is good. Sounds simple. We all know that this, is more complicated on the floors. We're here to support you guys. If you encounter any issues, please reach out to us. Again, this is just in summary, what we discussed here. And, there's continuous, review and improvement of our system processes to make sure we're taking care of our patients in the best way. And we all work together here. Thank you. That ends my presentation.
That was fantastic. I see Dr. Hajal and Dr. Remy in the back. This is standing room only in the carpenter room. Is that? Dr. Remy's a tad taller. So it's fascinating to me that the early study of early goal-directed therapy, subsequent studies show less benefit because the standard of care is getting better. That's kind of the conclusion.
Yeah, I think the focus on the fluid, which is also, if you ever round with us in the ICU, or you were big about like fluid stewardship, fluid management, I think that part has made also a difference. We're less likely to give extra fluid in patients with shock, more attentive about the variability and the underlying disease processes.
Let me pull the audience here in the carpenter room. Of all the residents here, how many of you were aware there's an order, there's a sepsis order set and have used it? Yeah, so one of the really important take-home messages, which we need to make viral, is sepsis order set, because it's really fantastic, because I think that's underutilized.
Yeah.
Right.
And one of the things, we work on, we were doing this a lot, when we were in all scripts, is having education sessions. And then Epic Transition, we've had a lot of growing pains and getting things to function the way we intend them to function. But, we're working on, the residents that do the EQUIPS curriculum, we kind of go over in our sepsis simulations. And, there's definitely opportunity. So if any residents are interested in quality and want to help with some educational initiatives, you know where to find me.
If you want to plot a plum crit and get it on your CV, get an abstract or something. So, what is this all scripts thing you mentioned? I'm not processing what that is. Exactly, yes. It seems like to me, like the details and the bundles are important, but the most important thing by far is not missing a case of sepsis, right? Because that's where the real delays are. And so I think, and then there's not a perfect, all the protocols are either too sensitive or too specific. Like SIRS is way too sensitive and not specific enough. And QSOFA, if there's already mental status changes, you're sort of far down the pathway. So I think everyone in the world is looking for that perfect kind of sensitivity and specificity of sepsis alert syndromes. You saw a bunch of them. Any comment on that?
Yeah, I don't think we're there yet. I think obviously there's a lot of research to be done, and I know Dr. Remy runs like an excellent research program that's looking at immunology and sepsis, and a lot of work has been done internationally. But until we get there, like this is what we have, and I think we can maybe use it to identify populations where maybe we have our blind spots. Which is one of the things we're trying to do too on the inpatient side. Is it a floor issue? Is it a patient population issue? Are there ways we can improve our care, trying to be a little bit more focused?
Yeah. So one of the blind spots I've noticed over the years is a patient who doesn't have a fever but has a worsening sinus tachycardia. So sinus tachycardia is a compensation for shock, right? And, heart rate goes to 105, 110, 120. By the time you're in the 130s, the patient's in trouble. And without doctors have heuristics or pattern recognition. A lot of times, unless there's an alteration in temperature, maybe the thought process isn't kicked in, or maybe the clinical unit isn't notifying the residents of a sinus tachycardia. But a heart rate over 120 as a sinus tachycardia, not a primary cardiac arrhythmia, that is a really sick patient, right? To get your heart rate to 120, you got to run up to tower 10 twice, And so if you're laying in bed and your heart rate's 120, that's someone who's starting to compensate for shock. And sometimes I think because there's no fever, the thought process for sepsis doesn't kick in. I want to, Dr. Shaw, she's either going to yell at me or say,
I just said, check your heart rate.
Yeah, everybody's checking their heart rate on their Apple Watch now.
It's like when I was younger.
Yeah.
Talk to them, Hijaz, your heart rate.
but some of the cases over the years, we've seen it like the quality committee. Actually, Dr. Herjal and I go way, way back. So for you young doctors, you may be shocked to know there was a time we didn't have rapid response code. What do we call them now? Right? There was no, and Rana had to fight for years to get the resources from the hospital. But see, you'd have a situation where the surgical patient's on tower 9, the heart rate's 110, the heart rate's 120, the heart rate's 130, the heart rate's 140. The busy surgical residents are, they're in the ER seeing patients in the OR. Next thing you know, there's a code. So the whole kind of rapid response was like, get someone there to see the patient who had sort of critical care, capability and knowledge.
So medicine, I don't think we miss the heart rate much, but
Yeah.
we miss a lot is a drop in blood pressure.
Yeah.
Like somebody's normal blood pressure is in the upper 150s and all of a sudden they're 105, 110. We tend to, it's okay, blood pressure. That we miss a lot. We don't do a very good job at really documenting neurologic exam and whether the patient is awake and alert.
Yeah.
We go to the bedside early in the morning and they're asleep. And then, we didn't wake them up. We never wake them up.
So for the Zoom, Dr. Jal had 2 comments. On the medical service, we don't miss the tachycardia as much, but sometimes someone whose normal blood pressure is high, who drops significantly, but not their mean arterial pressure is still over, 60 or 70. We underappreciate that as early shock. And then patients may altered and we don't really know it because they were sleeping in the morning and we didn't bother them. That's Dr. Hajal's 2 complaints. So
Agree.
so the best M&Ms are what Ron and I fight. So we need something to fight over, maybe a Friday. Well, pick a fight because we're, yeah.
I guess it's Friday.
Any other questions?
The question on the Zoom?
Yeah, I will
I had it in my,
maybe stop sharing somehow.
I do have a question, watching from video.
Yes.
Hey, my name is Randy. Just a question real quick. I've seen in the past, going back to getting the antibiotics quicker, trying to shave some minutes off that time to get the antibiotics bedside. I've seen in the past, and myself fault for this as well, when we're putting in for the VANC, we put in pharmacy to dose. I'm assuming then that's adding maybe unnecessary minutes with the sepsis?
100%. If the sepsis should be ordered, the sepsis, I said, the vancomycin, I think it's on, it's in the order set, should be ordered through the sepsis order set. When you put it, a pharmacy to dose, that goes through a different workflow, so it doesn't get, put into that, bucket of saying, okay, we need to get it to the patient as soon as possible. Now, we've been discussing with pharmacy different ways we can kind of improve our standard antibiotic dosing and kind of things on the back end, but for the time being, using the order set.
so you mentioned there's a sepsis order set?
Yes.
Okay.
There is, if you use vancomycin for pharmacy to dose, it gives you the option of first dose, you choose the dose, but you just have to click it and choose a dose.
Again, Dr. Jal said sometimes if you order vancomycin not in an order set, which is anathema to this conversation, but but in those situations where you do, you can order first dose stat and not have the pharmacy dose it.
Information.
The fructose is weight-based. So if you ever have a question of what dose, don't worry about the renal function for the first dose. That's in the maintenance doses, just weight-based.
And I'll repeat the point I made earlier. The minutes make a difference, but the real disasters are when we don't recognize it for an hour or two or something like that. And that's why we really gotta have, that's why, your very first slide, was the answer go to the bedside?
Yes, well, there are a couple of answers. I mean, you could also be thinking of maybe doing something else with your life as you're walking to the
Oh, yeah.
bedside, but yes.
Let me say one more annoying thing. In all due respect to the gadgets and AI and BI, please remember that you have an eye that is innate to you, that you are growing as you get older. So your native intelligence is far more important than anything else. At the bedside, you can learn a lot, and please do it. Go to the bedside and learn from the patients. That's my advice to you. The second thing I want to say, while it's very important to make the diagnosis of sepsis and treat it effectively and as fast as possible, it is also important to revoke it 2 days later if there is no sepsis. So just because somebody wrote in the ER sepsis or somebody decided sepsis and you proved it to be related to heart failure, then you say sepsis is revoked and this patient has heart failure. And that's very important to do. And the third thing to say,
Remember these three.
fluids are not
Yeah.
always your best friends.
Yeah.
Fluids maybe are okay in the beginning, but 2 days later, you cannot just keep on pouring fluids in people. Michelin people are not good. Make sure you get rid of fluids as soon as possible.
Okay. So basically what Dr. Hijal is saying, if you couldn't hear her in the back, is,
We're on the Zoom, yes.
we're on the Zoom. Assessing the patient yourself, your clinician,
But using your brain.
and using your brain. Making sure that, a lot of times we don't have all the facts in front of us at the time, we're making our best judgment. But 2 days later, if we've identified something else causing the clinical condition, making sure we're revoking the diagnosis of sepsis. And then lastly, fluids are not always your best friend. Fluids are medicine, so we need to treat them like medicine.
And,
Good enough?
Yeah, okay.
my goal when I'm on ID consults is always to stop more vancomycin than I start. Because but it's always okay to start it, but then you reassess and stop, and that's true. You start a sepsis, you go down the sepsis pathway, clinical information turns different, that's what Rana just said.
Any other questions?
I had one
in
question.
person?
So you mentioned a few kind of confirmatory tests for sepsis.
Yes.
Blood cultures being the gold standard, although obviously limited depending on what the source is. And then got a PCR for immunologic phenomena. What about PCR for like ribosomal subunits bacteria? Is there anything about?
Yeah, that's also, so you're opening up like a can of worms. So there's so many tests out there. So you can go on strategy, well, if I can't get my blood culture, what can I detect rapidly for like a pathogen and say, okay, I've identified a pathogen, there's my infection. So that may help you when you're trying to, target your antimicrobial therapy. But then there's also other tests out there that look at diagnosis, but also prognosis. So if my patient has this marker, they're more likely to do better or worse. So there's like a whole kind of slew of like different testing out there, which I didn't, highlight, like rapid pathogen testing or kind of what you specified, but that's definitely something you could potentially use, and I'm sure Dr.
Well, I'll put my ID hat on, and then, blood cultures never help you in the first 4 hours, because it take a couple days to come back. As an ID doctor, we always want blood cultures in these patients, because once you give antibiotics, you cannot get blood cultures you can interpret anymore. So blood cultures are a really important part of the database as you go forward, but they don't help you make a decision in the first 2 hours. And in terms of like molecular test on blood, we're not doing that.
Right.
For clinical specimens, the 16S ribosome test can be incredibly useful. But again, that's not really sepsis. It's really like the abscess or the spine infection with culture negatives, the 16S ribosome.
Okay.
But those patients are almost always seen by ID, and the way our hospital works is we have to actively request the 16S ribosome. There's no automatic trigger, which usually means like an email from the ID team to the lab people. Anyway, so that's kind of off topic, sorry.
No, it's very on topic.
Yeah.
So just for my understanding, sorry if I should know this, but like you can have fungal or viral or not, right? Okay, it doesn't have to be bacteria.
So if you think about viral sepsis, a full-blown case of influenza in a healthy young adult gives you SIRS criteria out the wazoo.
Right.
But most of those patients go home, maybe they get Tamiflu, maybe they don't. Obviously, COVID was a unique virus. And then real viral sepsis is incredibly rare and in immunocompromised patients. Like it's something that's really rare. And then again, fungal sepsis, again, that's really rare. And, you know, like we talked about histo last week at M&M's. There's occasionally immunocompromised patients who come in truly septic with multi-organ failure from acute, overwhelming histo or blasto or something, but those cases are super rare. So when you're invoking the sepsis protocol in the wards, unless someone's a truly highly immunosuppressed patient, you're really thinking of bacterial sepsis 99% of the time. And my critical care friends are not throwing things at me. They're shaking their head, yes. So yay.
You make me laugh.
Any other questions online or in person?
Well, as an institution, we're grateful for your leadership of sepsis along with your fantastic team. So thank
Thank you.
you. So.